This podcast is for general informational, educational purposes only and is not to be considered medical advice for any particular patient. Clinicians must rely on their own informed clinical judgments when making recommendations for their patients. Welcome, everybody, to another episode of PHM from Pittsburgh. I am still your host, Dr. Tony Tarchichi. For those of you who are new, welcome. And for those of you who are regulars, welcome back. I'm a med-peds trained pediatric hospitalist here at UPMC Children's Hospital of Pittsburgh in the Paul C. Gaffney Division of Pediatric Hospital Medicine. And we have been coming to you since October of 2016. This is our 10-year anniversary. I've been saying it all year. I keep telling you I'm going to say it all year long. I cannot believe we got this far. And I appreciate you all who are listening, who let us come into your earbuds or your phone or whatever you do. Thank you for doing it. This particular series, we were doing 2 series this year. This one is a big one, and I am happy that we're doing it because we want to give you good information. We want to help you take care of kids. If you're listening to this, you in some way, shape, or form take care of children who are sick in a hospitalized setting or an outpatient setting in some way. So we are here for you. I am sad that we have to do it, which means we've gone backwards in our society when we've made such great progress with vaccines. I am a big vaccine proponent. All of my children got vaccinated on time with the ACIP schedule. At the time, it was the CDC schedule, but that has changed. And so this is episode 2 of our Vaccine Preventable Illnesses series, Measles. Now, if you're a fan of the show, and if you're listening, I'm sure you are, you know that we've had a couple episodes on measles because there was the outbreak with Disney World. There was another outbreak, and we've had one expert on for all these episodes. So why break the streak? We are very fortunate enough to have friend of the podcast back on, Dr. Andy Nowalk, to walk us through measles. So Dr. Andy Nowalk's an associate professor of pediatrics and clinical director in the Division of Infectious Diseases in the Department of Pediatrics right here at UPMC Children's Hospital of Pittsburgh and University of Pittsburgh School of Medicine. He's a 1999 graduate of the MD PhD program at the School of Medicine, then did pediatric residency and infectious disease fellowship right here in Pittsburgh, and joined the faculty of the School of Medicine in 2005. He maintains clinical practice and an active research program in Lyme disease and serves as co-program director of the pediatric residency program. He has participated in data science research in diverse areas, including management and diagnosis of the febrile and hypothermic infant. He also has interest in vaccine counseling, especially in patients and parents who are vaccine hesitant. Now, before I say thank you and welcome on the show, I forgot to mention that there's no way we could do this series without help. So we have partnered with our colleagues in the Division of Pediatric Infectious Diseases right here at Children's Hospital of Pittsburgh. Without them, we couldn't have done this. And if you're listening, you've heard a bunch of them throughout this series, and we appreciate their partnership. And with that, Andy, welcome to the show again.
Tony, thank you again for the invitation. I appreciate it. I feel like you need like a Saturday Night Live 5-timers club or something. Or maybe I get a T-shirt that says I did 5 episodes of the PHM from Pittsburgh podcast, and all I got was this lousy T-shirt.
Oh, that's such a good idea. We may do that. That's great, Andy.
Yeah.
Well, we got to do, before we have even more fun, we got to do our disclosures. This is a CME podcast. I will go first, kick it out to you. I have nothing to disclose.
I have nothing to disclose except the fact that I think vaccines work and have saved millions of pediatric lives, which used to be non-controversial and weirdly has gotten a little strange lately.
It's gotten very controversial.
Yeah.
So now, Andy, we're talking about measles. So take us back. Microbiology 101, first year of medical school. Tell us about measles. Virus, fungus, bacteria, what are we dealing with?
Yeah, so this is a virus, and really, I think of this as a respiratory virus. Its portal of entry is going to be directly through the respiratory tree. There's all sorts of little bits of microbiology about it, like it's an RNA virus and it's a single-stranded and it's a negative sense and it's a member of the paramyxoviruses. None of that really matters other than it is a virus. And measles used to be called first disease in olden days when they used to give names to diseases. And there's a reason it was first, because it was so well known to kill children in the pre-medical days that it came first on the list of the most feared childhood diseases. So we've known about measles for a long time. Really, one of our most contagious, if not most contagious, pathogens ever. It's R naught, which is the value by which we kind of measure contagiousness and infectivity, is typically the gold standard for the most contagious. And just to give you a sense of that, it's R naught, which is like if you're in a room with a number of people, the R naught would say, if I'm in a room with 100 people, how many might I infect if I have a virus? And for measles, that number is around 18 to 20, period. And that's a really high number. And it's even higher than things that we think of as massively infectious, like TB or COVID or viruses like that. So this is a really super contagious virus that is very severe in its infectivity.
All right. We were just talking about, believe it or not, at lunch today at my division, we were just talking about the R naught of measles and how I think we thought COVID was like 4 and measles was like 14.
Yeah,
So it's a fascinating this came up. So shout out to Dr. Ben Miller who brought it up.
very good.
Now let's talk about, since this is such a contagious virus, can you tell us prior to vaccinations what the levels of incidence prevalence was, and then post vaccination what happened?
I mean, literally, this was a universal infection. That's why it was called first disease. Every child got it. So what that meant in the United States in like the 50s and 60s prior to vaccine was millions of cases a year. It was a universal. It led to a lot of morbidity. So estimates back then were somewhere around 50,000 hospitalizations a year, somewhere between 500 and 1,000 deaths per year. And remember, that's with about half as many people in the United States as there are now. So this was a really, really common illness to the point of being ubiquitous. And if you contrast that with now, this is one of my favorite charts. If you just look at measles incidence in the 60s through the 70s, you see this drop off, which is unbelievable when the routine vaccination came into view. So we went from millions of cases a year to hundreds of thousands to tens of thousands to a really dramatic decline. And by the time we got to the early 80s, we were talking about typically 100 or fewer cases a year. Now, there was a little bump up in the early 90s when the one-dose vaccine regimen was found to expose some folks later on in adolescence. And so we had a bump up and we briefly had 10 to 20,000 cases for a couple of years, instituted a second dose of vaccine. And then measles became so rare in the United States that measles was declared eliminated in the United States in the year 2000 by both the CDC and the World Health Organization. We were a model of eliminating
Wow.
measles.
My, how times have changed. That's really nice.
Yeah, yeah, amazing vaccine efficacy when you think about it.
Yeah.
Even though the individual vaccination was around 95% efficacy, when we got the whole population vaccinated, we just gave it nowhere to go.
And it bears repeating 500 to 1,000 deaths, million, you said how many hospitalizations? 50,000?
50,000 hospitalizations.
Yeah. I mean, that's time people have to take from work. That's
Sure.
completely preventable. 500 to 1,000 deaths, completely preventable.
Completely preventable. Yep,
Of
yep,
kids is something we'd love to avoid.
yeah.
So now, unfortunately, are having, and we've had this before. We've had you on the show for the issue with the Disneyland outbreak, etc. We are going to see kids, and there has been more cases this year than there has been in a long time. We're up to. Do you have those numbers for this year?
Oh, yeah. I mean, this year has been a barn burner, unfortunately, so far. Last year, just to give you the sense of it, last year was our biggest year since the early 90s when we instituted the second dose. We had more than 2,000 cases last year, almost 2,300 cases that were reported. Remember, there's the reported cases, and then there's a number of unreported, unrecognized cases. This year so far, so think of 2,300. This year so far, we're almost at 1,700. So in a
No.
quarter of the year, we've hit 1,700. do some simple math, we have a really, really good shot of breaking 6 or 7,000 in terms of our cases this year.
Yeah.
And the cases this year look like they did last year in terms of, there's a lot of kids under the age of 5 who are effective, about a quarter of the cases, but we're seeing a lot of cases in children in general under the age of 20. And, we're seeing just a ton of disease. Only a quarter of the cases in total are above the age of 20. And that's because vaccination is so common in that age group. All
Yeah.
those people are generally well protected.
Yeah. Wow. And when we're recording this, this is early April. So we're at 1700 in very early April. So this is not a great sign for the year. So
Yeah.
it's clear as day. We're on the lookout for it here at Children's Hospital of Pittsburgh. We expect to see it at some point. Let's remind our listeners how will a child who is unvaccinated who gets measles present?
I think that's probably a key thing to clarify. The unvaccinated child is going to present at first with a relatively undifferentiated febrile respiratory illness. So they're going to start with fever. They're going to start with what we were all taught in med school, the 3 C's, right? Cough, coryza, and conjunctivitis. Now, coryza stinks as a term because you're like, what the hell does that mean?
Yeah.
And that's just rhinorrhea. So they're going to have a runny nose, they're going to have a cough, and they're going to have some redness to the sclera. So, that's really the prodrome. As everybody knows, that's a non-specific prodrome. So how
Yep.
will you know? You won't. You need to really be thinking, is there measles in my area? Because you want to include it since those first couple of days are non-specific. There is some suggestion that the fever is higher than other respiratory viruses, although it's not that reliable in terms of that. And then, we could all look for Koplik spots, which appear before the rash appears, but Koplik spots don't appear in everybody. They're pretty hard to see in the prebuccal mucosa, and you have to look them up in a textbook to recognize them. So clearly, we're not going to pick up all of these kids who have measles because of Koplik spots. The thing that's going to help the most is really that rash. And that rash is a very distinctive rash. It's going to start typically on the head, and it's going to spread from the head down. So cephalocaudal in terms of the spread. And the key thing about the rash is the rash will clue you in. The morbilliform rash, as it's known, you're going to say, boy, that's heavy on the head, but it's a really densely red rash. I wonder if this is measles. Your problem is when you say that, you are infectious 4 days prior to the rash onset and 4 days after it. So you may already have had this kid sit in your office for a while and infect a ton of other people. And in fact, there are a handful of kids who will be infectious before the first fever. And so
Oh.
this is a very challenging situation in an outbreak, in that some of your cases are going to go so early in terms of becoming infectious that you may not be able to catch them quickly.
And now here in Pittsburgh, we have protocol in the ER. If someone thinks it's measles, they call you all, they put them in respiratory isolation. But for our partners in community hospitals and small hospitals around the country, maybe listening to us, and I'm sure they have protocols as well, but let's just play devil's advocate. They don't have a protocol. They're a brand new hospital that popped open. They're a small hospital. They would want to put these kids in respiratory isolation. Is that right?
They would want to put these in airborne isolation.
Airborne
Remember,
isolation.
this is a really contagious virus. I always think of, I want my MTV when it comes to airborne isolation. M for measles, T for tuberculosis, V for varicella. Those are the three big ones that'll drive airborne. COVID can be added to that, although we think COVID is a little bit less airborne and more contact now that we've gotten to know it better. If you're in a new community hospital, first thing, make sure you know where your negative pressure rooms are, because you
Mhm.
really want to know that you have the appropriate rooms. The next thing you want to train your whole staff to do is to get that kid in isolation, but slap a mask on everybody. That's one
Yeah.
of the things I really want to emphasize to people. They are going to be shedding a ton of infectious virus out of their respiratory tree. A mask on the infected patient is actually really effective, and it's really going to limit their shedding in their local environment. So first things first, get them into an appropriate room, hopefully with negative pressure. Go into airborne isolation, which means the kid and the family wears masks. And then you are going to go into airborne ISO. We all know this from COVID, right? Airborne
Yeah.
isolation means N95s with good fitting. And if you haven't
Mhm.
been fit tested and you don't know whether you're going to really be able to have a good seal, then put on a PAPR. Put on, one of the air-driven devices that'll protect you. Gown, gloves. And then especially if you are wearing an N95, make sure you get some eye protection here because the conjunctival mucosa is a route where you could get infected.
That's so helpful. All right. So now you've talked a little. Let's talk fully about the morbidity and then the mortality and even sequelae years later that come from measles.
Yeah, so again, a really morbid virus. Probably among the most common complications of it are other parts of the respiratory tree get clogged up and then bacteria take advantage of the viral syndrome. True measles pneumonia happens, but it's uncommon. Secondary bacterial pneumonia and otitis media are common complications. Otitis media, it depending on the series could be 1 in 5, 1 in 10. Community acquired pneumonia, secondary bacterial pneumonia on top, 1 in 20. So those are pretty
Wow.
significant complications. But one of the ones we don't talk about that I was never really taught about, but Paul Offit, for example, our good friend from Children's in Philadelphia, speaks so beautifully about is diarrhea and dehydration. So in the 1990s outbreak, Philadelphia had a really big outbreak in a few religious communities. And the main cause of morbidity and mortality in those kids was diarrhea and dehydration. It killed kids in Philadelphia. So don't forget about this. They can have a really significant amount of diarrhea and they can dehydrate really quickly between the diarrhea and the high temperature and a small
Mhm.
child. You can really have insensible losses that go crazy very, very, very quickly. The rarer complications are the ones that can often result in death, though. Encephalitis is really bad and it has a very high mortality rate. A lot of people will remember Roald Dahl's daughter died of measles. I often will quote the Roald Dahl page that he talked about his daughter being fine, developing symptoms, and then being dead within 24 hours.
Mm.
And those are just the immediate complications. So, you die from the encephalitis, you die from the pneumonia. Immune compromised people obviously at higher risk for both of those. And then the late complications, which are rare, I mean, they're like 1 in 10,000 is SSPE, subacute sclerosing panencephalitis, but it's just as terrifying. I mean, it's a universally fatal neurologic complication where years later, you can recover virus from the central nervous system. It's terrifying.
Mm.
And I want to highlight for that when we have younger infants who get infected, younger infants, less immunity, you get infected under the age of 1, particularly around 6 months, your rate of SSPE goes up over 1 in 1,000. So,
Oh,
there
wow.
are short-term complications that are terrifying, and then the longer-term complications are also terrifying. Rare, 1 in 10,000, rare, but that's 1 in 10,000 child who's going to die from measles later on,
Yeah.
which kind of highlights why this always terrified us.
It highlights it very well, Andy. And the one question I didn't plan on asking you, but it popped up in my head, I'm wondering if you can help with, is if you have a patient who's vaccinated, but then unfortunately has to be on immunosuppressive agents, whether it's for cancer or rheumatologic causes or whatever, how do you treat that patient if they're exposed or if they have measles?
Yeah, so if you have an immune compromised patient who's been vaccinated, good on you that they're vaccinated. Some of our kids, remember, become immune compromised under the age of 1 and they never get to choose to be vaccinated. For the most part, our guidance there is that we're going to use measles immune globulin and exposure. Measles IG, remember, can be used up to 6 days after exposure. It's not 100% effective, but it is one of the things that we have. For a lot of immune compromise, we can't use our best preventive measure, which is if I have a kid who's gotten 1 dose of vaccine and they got exposed to measles, I give them another. And if they've got
Yeah.
0 doses, I give them 1, especially if they're under the age of 12 months, but above the age of 6 months. So our best preventative is still vaccine, even if you've been exposed. In the immune compromised, though, we often will give a lot of measles immune globulin to try to protect them as much as we can.
I wanna stress what you said. So if you are in an area that's exposed and there's a measles outbreak and you have patients who are not vaccinated and are not immunocompromised and get exposed from a friend, sibling, whatever, you can, as long as they're over 6 months and under 12 months, you can just give them a dose, and if they're older, you can just vaccinate them, and that will protect them. How well does that protect them? People may wanna know that.
It's really high. I don't know the statistics specifically, but it's in the high 90s in terms
Okay.
of percentage protection. And I wish we had seen a little more advertisement because when we talk to our colleagues, particularly recently in South Carolina and last year in Texas, turns out that the news didn't really advertise the fact that tons of people came out to get post-exposure vaccination.
Okay.
When that hit those communities, we had a lot of advertisement of folks who made poor choices, didn't vaccinate, and got measles, sometimes intentionally, which is unbelievable to me. But nobody really did big stories on the tons of parents who then recognized their kid was at risk and then took them to get a first or second dose of vaccine after exposure. It's incredibly effective at preventing infection.
That's such a heartwarmer. That's a nice story. We haven't had
It
many
is.
nice stories. Yeah.
Yeah.
Now, we talked a little about treatment. You've talked about post-exposure. You could get the vaccine. You've talked about measles immunoglobulin. If you're unvaccinated, if you have a patient who's unvaccinated and has measles, what are our treatment options?
If I were to really sum it up, what I would say is nothing, really. I mean, treatment for me implies something that can reverse the course of disease. I have a child with bacterial meningitis. I give them intravenous ceftriaxone. I have a child with herpes encephalitis. I give them intravenous acyclovir. Both of those, even though it's a serious illness, I expect to really decrease the rate of complications and really to help that child do better. We don't have that for measles, but just simply put, I mean, the foundational piece is supportive care. And certainly we recognize that there's no antiviral therapy that works. You may say, well, what about ribavirin? It's been reported in the immune compromised. It's not been studied. It's a desperation measure that we throw at the wall when a patient's dying. And so really, it's supportive care. Vitamin A in places where there are children who are malnourished definitely has a positive effect. There's been no study of vitamin A in children who are healthy and really well nourished about whether it modifies disease. In severe cases, we give it because it's something that we give. But again, it's not a treatment so much as I hope that maybe this will have a little bit of an ability to help a child. There's no real treatment for measles. There is supportive care.
So let's stress that. So vitamin A, which has been all over the social media, is helpful in malnourished children, in children and in the US, overwhelmingly, thankfully, children are not malnourished. They're well nourished. There's no data to say that it helps. We use it in desperation moments to try something because the child's critically ill and we're concerned for death.
Absolutely. I mean, remember that vitamin A has its own downsides, and so hypervitaminosis is a syndrome. But we will use it in some situations, but it doesn't qualify as me calling it a treatment.
And what about measles immunoglobulin? Do we have enough to go around for everyone getting measles?
Right now we do for all of our exposed, immune compromised and infants. Remember, infants under the age of 6, that's what we're going to do with them as well. We're going to hope that
under 6 months or 6
under
years?
6 months. 6 months.
6 months.
Sorry,
Okay.
Over 6 months, remember, you think of, I'm going to start vaccinating for measles with MMR at 12 months, but in outbreak situations, you can give that dose as early as 6 months. You just won't count it in their schedule. What I'm really hopeful for is good moms around the United States continuing to donate antibody to those younger infants, which is the most protective thing that we have. But I mean, I think we have enough now, but that's one of the many reasons I hope that this outbreak really continues to get tamped down where we can be able to do it.
And in an immunocompetent child above 12 months old, would you use measles immunoglobulin at all?
No, if you have a vaccinated child above 12 months old, I'd probably give them another dose of vaccine for prevention. But after that, I would probably not give measles immune globulin in that situation. One dose of vaccination is actually really good. It's low 90s in terms of protection. That second dose is what pushes our protection level up into the upper 90s. But once you get that one dose, remember, we talk about vaccines in terms of protection all the time, and then we forget a really powerful thing that vaccines do. Oh, I got measles. I was not in the 93%, I was in the 7%. The measles vaccine is still giving you benefits in those situations. And this is the same thing that we see, Tony, right, with influenza vaccine. We say, oh, the influenza vaccine's only 30% effective this year. Effective means prevents culture-proven influenza. But we have really good data in the last decade that says, okay, I got influenza. I'm vaccinated. What happens to me? I'm much less likely to go to the doctor, much less likely to be
Hmm.
hospitalized, much less likely to die from
Yeah.
influenza because I'm vaccinated. So, modification of disease, which is a very big deal for flu and a very big deal for COVID with their vaccines, same thing with measles. You get that dose of vaccine, you're going to modify and lessen the severity of disease. That one dose does a good job at modifying disease, even if you get infected.
That's fantastic. What I'm asking, I guess, is in an unvaccinated, immunocompetent patient over a year old,
Oh,
would you
unvaccinated. I'm sorry.
unvaccinated? That's okay. Everything you said, I loved, so I'm happy you said it. But unvaccinated,
Yeah.
immunocompetent patient over a year, would you give immunoglobulin?
Not if it's within the first 3 days.
Okay.
And immunoglobulin, here's the thing, immunoglobulin is not gonna do anything after those first 6 days, because once the infection gets going, the antibody that you provide through the immunoglobulin is not gonna modify the course of disease. So we don't that's now I'm sorry, I misunderstood
That's
the
okay.
question a little bit. Now that, I have it in my head, immune globulin's not gonna do anything after that first little stretch of disease. So your option in an unvaccinated child over the age of 1 is to give them a dose of vaccine if they're in the first 3 days. If they're in the first 6 days, you could give them immune globulin, but then after 6 days, there's nothing to do other than support the child through the illness.
That's so helpful, and everything you said, super helpful. I loved all of it. So now the question is, if you're in a community with an outbreak and you're vaccinated and you're in the movie theater with everybody else who has measles and you didn't know it, and so you're clearly exposed heavily, what should you worry about? What will happen to you?
Well, hopefully that you are one of the individuals in the United States who's received adequate measles vaccination. And that
Mhm,
for almost everybody we're talking about means 2 doses of vaccines. I have some more senior people in this building who qualify for I had wild type measles in their childhood, but
mhm,
they're fewer and fewer because this vaccine's been out for 60 years. So there's relatively few of those folks around who are in practice in the building. So
mhm,
almost all of us have had 2 doses of vaccine. If you have a protective titer that goes with it, let's say you had 1 dose of vaccine, but you have a superb measles titer, you're also protected. In that movie theater with that 100 people, where, we know that of that 100 people, when that one measles person is breathing around, they're gonna infect maybe 20 people around them. If you're sitting next to them, the likelihood with 2 doses of vaccine that you will become infected is really low. It's in the low single digits because the vaccine is so protective. And if you get infected, you
mhm.
are very likely to get very modified disease. We saw that here in 2009 when we had a patient with measles come through our ER for the most part because that patient passed by a lot of kids who had gotten 2 doses of vaccine. Nobody got infected, but we had a couple of older caregivers in the ED who were vaccinated but got measles, and what they got was very mild and modified disease. That's the beauty of the vaccine. Even though it technically didn't work, it protected them from severe disease.
And today, that's very helpful to know because, the South Carolina outbreak and Texas outbreak, as you already talked about, worried people, and there's more we expect more outbreaks to come.
Yep. Yep. So I
Well,
think a
go
big thing that comes up, Tony, is like, do I need to go and get another booster dose? I get asked that all the time.
oh,
If you've had 2 doses and you're a healthcare worker, you're considered protected. Some folks are required to get measles titers at their work. If you had a titer that was not detectable, most of the time you're still protected, but you're welcome to go ahead and get a booster dose because all it will do is boost your immunity. You're not going to get measles from the vaccine. The only times I would say, hey, don't get a booster dose if you're eligible is if you're immune compromised. We know that
mm,
people who are significantly immune compromised, and some of my colleagues here work with immune compromised and they're getting adequately treated for significant diseases. Maybe they have a recent diagnosis of cancer, or they're recovering from lymphoma, or they're getting other immune modulators. That's a time where you really do not want to get live viral vaccines unless you've checked it out with your PCP and probably an infectious disease practitioner.
now, Andy, the one thing we have to bring up because this is all over social media and people are still worried about it and still talking about it, the vaccines connection to autism. I'll let you take that.
Yeah, so I mean, we have mentioned this before.
Yes.
Um, this is one of the most powerful myths that's out there. It was really propagated because of a single discredited paper in the late 90s in England. A single practitioner published a series of 12 children with no controls, and as it turns out, falsified the data. And as it turns out, also, this guy was being paid by a law firm to try to promote lawsuits, and himself was trying to develop a measles alternate vaccine that he could sell after he disseminated this misinformation. We've been
Terrible.
dealing with that ever since. And all we've done is look at literally millions of children over and over again in the US. Kaiser Permanente and multiple other groups have looked at it. In multiple countries in Europe, where they keep track of everybody who gets vaccines in their country, and around the world. And we have never shown a significant association between MMR and the administration of MMR and the development of autism. Certainly autism rates have increased in the last few decades. All of us in pediatrics know that that is almost certainly mostly due to increased diagnosis, which is good, and we need that.
Yeah.
And that we also recognize that there seems to be a little bit more even than could be accounted for by increased diagnosis, but that's not due to vaccines. And
Right.
the thing that drives me crazy as the father of an autistic child is the amount of energy being put into an absolutely dead hypothesis that has been disproven over and over again now by various sources around the United States. People are like, let's study it again, rather than putting money into better research on other causes, as well as better ways to care for our kids in our community with autism and help them to thrive. So the money's going to the wrong place. It's going to a completely discredited hypothesis. And the reason it's going there is those people want to make money off of other people. And that's it.
Mm.
This is not about a noble cause. This is almost always linked to money. And all you need to do is read a little bit on various news sources where you can trace a lot of these campaigns back on Facebook, on Instagram, and on Twitter, which I refuse to call X. You can find it being traced back to a very small number of people funding these ads and memes through various bots and other misinformation sources. So this is not a ground roots effort to increase awareness. This is a sophisticated media campaign intended to sow distrust in one of the most effective vaccines we have.
And as Paul often said, unfortunately, the misinformation is way better funded than actual information.
Yep.
It's very unfortunate. There's nothing I can add. I agree with everything you said, Andy. It was perfectly said. So I'm hoping we can put this issue to bed when there are real issues with measles, especially now in the U.S. We're seeing more of it. We've already had pediatric deaths, one in Texas. We are expecting more if this thing keeps going up. We as pediatricians would like not to have pediatric deaths. I can't believe I have to say that, but I do. So we would like everybody to get vaccinated because we simply care about the children. And the ridiculous myth that all doctors are getting kickbacks from pharmaceutical companies is just not true. Absolutely not true.
It's just absurd. I mean, there's a lot to really make you hang your head, but I will reflect on, I'm a hopeful guy. And so what I will reflect on is that whenever we look even now, when you as a physician, particularly as a pediatrician, walk into a room and engage a family in a vaccine conversation, I know it feels more fraught now than it ever did before. And you have a lot of reasons to not routinely ask, did you get your flu shot? Did you get your COVID shot? Did you get your MMR? But there's been no real change in the overall rate of who's effective in that conversation. We are more effective than the social media still. And so if you're willing to fight that fight, yes, you're going to run into some very, very challenging encounters because the folks whose minds are set even more than they were before.
Mm-hmm.
But a lot of parents are in that room sitting on a little bit of misinformation, but in general being like, I'm worried, but these diseases sound bad. And when you connect to them and find out where they got their information and then say, hey, I'm just here for the same reason you are. I want your child to be well. And let me tell you what I think about this vaccine and what I've seen it do in terms of protecting children. That is still powerful. So don't give up on that. Even I hesitate sometimes, and I'm supposed to be the one who has those conversations most aggressively. But even I sometimes am like, oh boy, because I'm nervous more than I ever was before. But when we do it, we're effective. So, keep trying. Keep trying. It's a really, really powerful thing when you can connect with a family.
It's such good advice. And that's why we're doing these episodes to give all healthcare workers all the information they need when they're having these discussions to give good information. And we had Glenn Repczynski on who really talked to us about approaching this in a non-judgmental, humble way. Most of the parents there, their minds are open in that they want to do what's best for their child. They're worried, they're afraid, and we can be comforting and helpful with good information, and maybe you'll take a couple conversations.
Yeah. Yeah. I mean, I always talk about seatbelts too. And I'm like, do you put a seatbelt on your kid? And everybody does.
Yeah.
And some people will say, well, I only do it because it's the law. And I'm like, why do you think it's the law?
Yeah.
Do you think it's the law because car manufacturers love adding things to their cars that are expensive? Or do you think it's the law because it saves lives? That's the reason it's the law for schools to vaccinate. It saves lives, and measles vaccine is way more effective than a seatbelt, as it turns out, in terms of protecting you when measles comes your way.
Well, Andy, this is everything I wanted to cover. This has been great. I always give our guests, as you know, you're a longtime guest, you're a regular, the last word. And is there anything we did not talk about that you wanted to make sure we talk about?
No, I think that what I would say is I think that we're going to continue to see smoldering outbreaks,
Yeah.
but I don't think that we're going to see 10, 25, 50,000 cases in the US because we haven't done that bad of a job. I mean, if you look at school age vaccination rates, they're low enough now in most states that we're going to see cases burn for a little while in a community. But most of the time, South Carolina is the case of this, and Texas too, believe it or not. These outbreaks reach the wall of the vaccinated and they just die off because they can't go anywhere. Once they get outside of these clusters of unvaccinated individuals, typically the transmission chain eventually stops. South Carolina has burned out, and it's burned out for two reasons. Number one, it chewed through a lot of the susceptibles, but number two, a lot of people were like, wow, measles in my community, that's not good. Maybe I will get my kid vaccinated. And many of them got vaccinated because they heard that on TV, but a number of them got vaccinated because they were in a room with a pediatrician and said, what do I do? And a smart pediatrician said, hey, I'd be worried too. Let me tell you what I know. And that made the difference. So don't give up. Let's keep vaccinating everybody who's open to it because we're going to continue to build that wall that's going to protect us.
I love that. Well, there's no better way to end, Andy. I am going to end it there. Thank you for joining us as always. I love having you on. Thank you very much.
As a reminder, free CME is available and it's courtesy of the University of Pittsburgh. Just click on the link under the podcast description and follow the instructions. Thank you to the UPMC Children's Hospital of Pittsburgh and especially the Paul C. Gaffney Division of Pediatric Hospital Medicine.
Thank you again to our expert guests and special thanks to all of you who take the time to join us. We know that your time is valuable and we appreciate you sharing it with us.
Please feel free to email my dad at tony.tarchichi@chp.edu for any questions, comments, or podcast ideas.
As always, thank you for listening.